Thank you so much, and I'd like to take this opportunity to thank the organizers, particularly Jeff and Shiv, for inviting me to this wonderful symposium. I really have learned a lot during the last 24 hours. I'm going to be speaking on, as you see, what do we know about autonomic nervous system and its regulation, particularly from the stimulation of the parasympathetic nervous system. And these are my disclosures. Now, we've known for a long time that in heart failure there is autonomic imbalance, which is characterized by increased sympathetic activity and withdrawal of parasympathetic activity. Autonomic imbalance is, and the related RAS activation is associated with progression of heart failure and worse outcomes. Whereas we've done a remarkable job in blocking sympathetic nervous system and the RAS activity, and that has resulted in remarkable improvements in outcome in patients with heart failure, the same cannot be said about improving parasympathetic activity in heart failure. And one of the major problems, of course, is that to the mere clinician like myself, there really aren't any measures of directly looking at vagal activity or parasympathetic activity in patients with heart failure. We use a number of these surrogate markers, but they are not easy to use in the routine clinical sphere. And moreover, no drugs have been approved to enhance vagal or parasympathetic activity in patients with heart failure for a prolonged period of time. Fortunately, however, there are at least 3 animal models that have tested the hypothesis that increasing vagal tone by directly stimulating the vagal nerve would result in improved outcomes. And so let's spend some time to very briefly look at these models. The first one is the rat post-infarct model. And first was described by Lee and his colleagues. They used the post-infarct to create a heart failure and then divided into 2 groups, treating them with the right vagal nerve stimulation in one group for 6 weeks, 14 days after the post-infarct, using stimulations at 20 hertz, 10 seconds on and 50 seconds off duty cycle. The intensity of the current was adjusted to decrease the heart rate by about 20 to 30 beats per minute. And they found that although the vagal nerve stimulation did not have any effect on the infarct side on the far left top picture, but it did significantly improve remodeling and had a remarkable effect on decreasing norepinephrine and plasma BNP. And remarkably, this was accompanied by a considerable reduction in mortality in the group given VNS or vagal nerve stimulation, a 73% relative risk reduction in all-cause mortality. Now, the second model was in dogs, in the pacing-induced heart failure dogs. There were 15 mongrel dogs in this study, and they produced heart failure by pacing them at a rate of 200 beats per minute and for 4 weeks, and then at 180 beats per minute for 4 weeks to maintain heart failure. Half the animals were then given implanted with the Cyberonic VNS system without an RV lead to to control for any RV feedback that wasn't needed. This was an open loop system, and the right vagal nerve was continuously stimulated at a duty cycle of 4 seconds on, 12 seconds off at 20 hertz, 0.5 millisecond pulse width at an intensity to reduce the heart rate by about 20 beats per minute. I'm particularly telling you these settings of stimulation because I think we'll come back to that later on when we are talking about the human experiments. Now they found that there was a very nice improvement in remodeling, attenuation of the left ventricular end diastolic and systolic volume, and an improvement in ejection fraction in the animals treated with VNS compared to those controls. And on the left side, you see this was accompanied by improvement in high sensitive CRP, as well as reduction in norepinephrine and angiotensin II. Now, the third model was Tony Saba's model of microembolization in induced heart failure, and his group looked at vagal nerve stimulation using the biocontrols cardiofit system. And we'll come back to that later on. They stimulated the right vagal nerve again, synchronous with the cardiac cycle, in order to reduce the heartbeat by about 10%. On an average, the reduction in their experiments was about 10 beats per minute, but the range was wide from 1 to 28 beats per minute. They looked at data at baseline and 3 months follow-up. And you see here, vagal nerve stimulation had a remarkable effect on attenuating and in fact reversing remodeling, both in systole and diastole for LV and diastolic and in systolic volumes, and a significant increase in ejection fraction. Interestingly, they also found that there was attenuation of the inflammatory cytokines in these animals, reduction in tumor necrosis factor alpha and in interleukin 6. And when they looked at the histology of their animals, there was a reduction in the interstitial fibrosis in the VNS-treated animals, as well as a significant increase in the capillary density in the myocardium. So you see, these 3 sets of experiments teach us that vagal nerve stimulation in the experimental heart failure models may be accompanied by improved LV structure and function, decreased interstitial fibrosis, improved cytokine profile, and may result in improved survival. And on the basis of these data, the group in Italy, led by Peter Schwartz and Di Ferrari, went ahead and did the first in-man experimental stimulation of vagal nerve in patients with heart failure. Started off with just 8 patients, and then they enlarged it to a multi-center European study of 32 patients. The patients were in class 2 to 4, predominantly class 2 to 3 patients, left ventricular ejection fraction less than 35%. All their patients were in sinus rhythm. They were medically treated with all the heart failure drugs, including beta blockers. And the primary endpoint of the study was the safety and side effect endpoints. And the secondary endpoints were efficacious endpoints, looking at objective endpoints, LV remodeling, LV ejection fraction, and diastolic and systolic volume, as well as the subjective outputs of improvement in symptoms, NYHA, 6 minutes walk, quality of life using Minnesota Living with Heart Failure questionnaire. And they also measured heart rate variability. This is the design of their experiment. The right cervical vagal nerves was stimulated using the CardioFit biocontrol device. Stimulation was titrated starting 2 to 4 weeks after implant at 1 to 2 hertz, synchronized to the cardiac cycle. The target current was 5.5 milliamp, or a reduction in heart rate to 5 to 10 beats per minute, or the onset of intolerable side effects when they increase the current of the output system. Patients were followed at 3 to 6 months, and there were about 23 out of the 35 patients who could actually be followed at 1 year as well. And you notice here, these are classical patients. They're somewhat younger than you'll see in our usual practice, predominantly class 2 and 3. But the point to make over here is that they were so well treated. Look at that, ACE inhibitor, beta blocker, loop diuretics, even aldosterone blockers, and nearly 2/3 of these patients, nearly 60% of the patients were also had previous ICD implanted. The safety data showed that there was really no concern about safety using vagal nerve stimulation. Implantation was successful in all of them. Device or procedure-related adverse events occurred in only 2 patients. One had acute pulmonary edema soon after the implantation, resolved quickly with IV diuretics, and 1 patient needs surgical revision. That also was successfully carried out. There were anticipated side effects which were all resolved, usually cough, dysphonia, and mandibular pain, which are well known to occur whenever the vagal nerve is stimulated, and we'll see some of that other data later. There was quite a significant increase in ejection fraction at 3 months and then at 6 months, and this was maintained in the number of patients that could follow up at 1 year, coming to the order of about 10 to 12% points. There was also improvement in NYHA class, which was sustained at 1 year. There was improvement in 6-minute walk that occurred by 3 months, and there was no further improvement of this parameter. And the same was true for the Minnesota Living with Heart Failure score. Major improvement, or most of the improvement, occurred at 3 months with no further change. So looking at this data, one could conclude that chronic VNS in heart failure patient is safe. Chronic VNS may improve symptoms, LV structure and function, and quality of life, and exercise capacity. But there were several questions that remain to be answered, including which site should be used, the right or the left vagus nerves. All the previous data, the animal data, as well as this human study, used the right vagal nerve, but could we not use the left vagal nerve? That was one question that we need to resolve. What is the intensity and the protocol of stimulation? All use different protocol. The animal in this animal models and this particular study, should it be synchronous or with the cardiac cycle, or could it be independent of that, not having a right ventricular lead to be synchronous with the cardiac beat? What should the duration of on or off cycle be? What is the role of heart failure reduction? And that, of course, is a very important question, because is heart rate reduction contributing to the beneficial effect of vagal nerve stimulation? If that be the case, then we have very effective new medications that predominantly and exclusively reduce heart rate, and there would be no need for vagal nerve stimulation and all that and gets involved with that. So that's a question that needs to be addressed. What are the ideal patients who are likely to benefit, and what are basically the mechanisms of these remarkable effects seen in the animal models and in this particular first in man study. Now, to address some of these concerns and questions, we carried out the Anthem heart failure study, which was presented at the Hotline Heart Failure meeting in ESC in August and September last year, and was published simultaneously in the Journal of Cardiac Failure. The study was carried out entirely in India, and the objectives were really to evaluate a new autonomic regulatory therapy, or ART, with left or right vagal nerve stimulation for the treatment of chronic symptomatic heart failure with reduced ejection fraction, and to test the feasibility and tolerability of this particular ART system. And for that, the primary safety endpoint was the incidence of procedure and device-related adverse events during the entire 9-month duration of the study. And the primary efficacy endpoint was changes in left ventricular ejection fraction and left ventricular and systolic volume at 6 months. We had several secondary endpoints, and these were changes at 6 months in left ventricular and systolic diameter, 6-minute hall walk, quality of life, NYHA class, heart rate variability, and blood markers like BNP and CRP. The key inclusion criteria were patients with stable heart failure, ejection fraction less than 40%, who had dilated heart but did not have dysynchrony and were being treated with optimal pharmacological therapy for at least 3 months. The key exclusion criteria included any degree of heart block and primary autonomic dysfunction. Here is the design of the study. After baseline assessment of these patients, they were randomized to left or right-sided vagal nerve stimulation. 2 weeks later, vagal nerve stimulation system was activated, and over the next 10 weeks, the stimulation parameter was up-titrated, and at the end of which, after the end of titration, cyclic VNS therapy was instituted in all patients throughout that 6-month period, and outcome measures were measured at 3 and 6 months, whereas safety and adverse events were assessed throughout that 9-month period. Here is the protocol. The vagal nerve stimulation system that we used was the Cyberonic system that's been used for over 100,000 patients with a left-sided implant in patients with epilepsy. And so we know a great deal about the side effects, etc., from those 100,000 patients. The device was implanted on the left or right vagal nerve by the surgeon without RV sensing. In other words, this was an open loop system. Chronic intermittent stimulation was then delivered at 10 hertz, 250 microsecond pulses, and they were delivered in a duty cycle of 14 seconds on and 66 seconds off. The intensity was then titrated over the 10 weeks to a maximum tolerable current below the threshold of side effects or heart rate changes. The heart rate was continuously monitored during the up-titration phase to confirm that no heart rate changes actually occurred. And over time, the threshold effect gradually increased. Patients could tolerate the current at a higher level, so that the average stimulation current was 2 plus minus 0.6 milliamp at a frequency of 10 hertz, which happens to be the frequency at which vagal nerve fibers normally discharge. There were 78 patients that were screened, 60 were randomized, 29 on the right side, 31 on the left side. One patient on the left-sided implant died soon after the procedure because of a procedure-related embolic stroke. There were 2 further deaths in the left-sided implant patients. Both were unrelated to either the procedure or the device, and one was a heart failure death, the second was a sudden cardiac death. So that at the end of both 3 months and 6 months, we had 29 patients with full data on the right side and 28 on the left side. Now, the baseline characteristics show that these patients were much younger, and that's what you get in India. The heart failure occurs at a much younger age. Etiology was ischemic, as in this country. Majority of patients were class 2. Body mass index showed that these patients certainly are much smaller than those we see in the United States. Ejection fraction was 32. They had large hearts, as you can see from the volume data, and the heart rate was 78, and systolic and diastolic blood pressure is consistent with severe heart failure, and none of these patients had an ICD implanted. They were, as you see, very well treated. All of them were on beta blockers, 85% on ACE inhibitors or ARBs, 3/4 were on aldosterone blocker, and a third on diuretic, digitalis. Now, the primary outcome, which is the primary safety outcome, the serious adverse effects were seen in 21 patients from the pooled analysis. There were no difference on the left and right side. There was one related SAE, which of course was the one I mentioned before, an embolic stroke occurring soon after the procedure. The others were unrelated and equally distributed between the left and right side. The most common non-serious side effects were voice alteration, hoarseness, cough, also oropharyngeal pain, equally distributed again between the left and the right side, and very consistent of what is seen in patients with VNS carried out for epilepsy or for depression. There were no implant-related infection, system malformation, and none of the patients or the physicians or PI requested for early termination of the study, suggesting that the procedure as well as the device was well tolerated throughout the 9 months study. Now, this shows us the primary efficacy endpoint, and you see in the pooled analysis there was a 4.5% increase in the ejection fraction, very similar in the left and right side. The left ventricular end systolic volume also decreased, but not significantly. Notice how wide the confidence intervals are. There was a suggestion that maybe the right-sided stimulation had a better response than the left, but again, the confidence intervals are so wide that we really can't make any meaningful statement. Here are the secondary endpoints, and again, these are pooled. There was no difference between the left and right side, but notice how the end systolic diameter, the left ventricle, increased significantly. There was a significant improvement in NYHA class of 6-minute walk, Minnesota quality of life, heart rate variability improved by 17 millisecond. Heart rate decreased on an average by about 4 beats, and this is data from the Holter monitor. So that would suggest that maybe the heart failure had improved in these patients. So we have some objective measurements of heart failure improvements, some of the echo parameters, as well as heart rate variability and heart rate. BNP was not changed, whereas CRP was reduced by 0.4 milligrams per liter. Now, there were, of course, several limitations in this study. This was an uncontrolled open label study, and therefore placebo effect may have contributed to some of the observed changes, especially the more subjective changes that we'd measured. Although no significant differences were observed in any outcome between the left and right side, the confidence interval, as you saw, were very wide, and some difference really cannot be ruled out. The study, as I mentioned, was conducted in India, and therefore the results of the study really cannot be generalized to other populations. So to conclude then, Anthem HF approach to heart failure, which was chronic, low amplitude, natural frequency stimulation of the left or right vagal nerve, it was feasible, is feasible, and was well tolerated. There were really no safety concerns. Both left and right-sided out was associated with improvement on both objective as well as subjective measurements of cardiac function and of heart failure symptoms. Clearly, we need to carry out further investigation of this particular art therapy in larger controlled study. Now, at the same meeting, there was another late-breaking trial, and this was the Nectar heart failure study. This was a larger study, 96 patients compared to our 60, and more importantly, I think the more important aspect of this study is that all patients received the implant. The idea being, can you overcome the placebo effect of which we are so well aware? Out of the 96, 60, they were randomized in 2:1 for therapy on or therapy off, so that 63 patients received the therapy, whereas 32 did not. At the end of the 6 months, 59 people had paired data on the therapy side and 28 on the control side. Unfortunately, none of the primary or secondary endpoints in this study were positive. So for all intents and purposes, this really was a neutral study. This is data for the primary endpoint, or LV and systolic dimensions, and these are the secondary endpoints of LV volumes in systole and diastole and ejection fraction. But this study really contributed quite importantly, in my mind, to an important question that we will have to address when we take this therapy forward, the question of blinding. As you know, that the primary echo endpoint was blinded. However, given the situation, given the kind of therapy, many patients, perhaps most patients, do feel the sensation whenever vagal nerve is stimulated. So at 6 months, the investigator asked the question to these patients whether they believed they were randomized to the off or the on therapy. And the blinding index from that data was calculated. Index of 0 means the blinding is perfect. Index of 1 means they are completely unblinded. And if you look at the data over here, you will see in the off group, they could, 55% of the patients correctly said that they were in the off group. Whereas in the on group, 77% said correctly they were in the on group. Clearly, blinding was not very effective. And this is a question that is going to be raised. How do we design studies that are where we use these sophisticated devices? And the question is the same that was recently posed when we had the results of the recent renal nerve denervation. Now you see there are 3 trials that we've talked about. If you look at the study name, it's CardioFit with the original proof of concept study, 32 patients. The Nectar heart failure study, that was a neutral study. Anthem's heart failure that I've talked about. And the last study is ongoing. This is a large study called Innovative Heart Failure. 650 patients are going to be randomized in 3:2 randomization, 3 active treatment and 2 standard of care. So the 2 ones will not be implanted with any device. Patients will be class 3 heart failure, ejection fraction less than 40%. The right cervical nerve will be is being stimulated, synchronized to the cardiac cycle. So this is really replicating the same program as the original proof of concept cardiofit study, using almost entirely the same protocol, except for the fact that this is an all-cause mortality and morbidity study, so it's a phase 3 trial. The study started in February of 2011, and the results are expected not before the early 2018. So you notice we have at least the results of these 3 studies. The first 2 studies did show an improvement in cardiac function and symptoms of heart failure, but the 3rd study was neutral in all dimensions. The question arises, how do you explain that? And I think the answer probably arises in what kind of stimulation parameter we used for these in these studies. In the Anthem heart failure, the stimulation was at 10 hertz, and the maximum amplitude that was achieved on an average was about 2 milliamps plus minus 0.6 milliamps. The cardiofit study used a very low frequency, 1 to 2 hertz, synchronized with the cardiac cycle, but were able to achieve a much higher stimulation amplitude of 4.1 plus minus 1.2 milliamp. And finally, Nectar used a very high frequency of 20 hertz and were only able to reach a threshold of 1.2. Clearly, what this tells us is that the higher the frequency you use, the less intensity of stimulation you can use from the current standpoint, because the patients feel the current much more at higher frequency. What is the best thing? This is what the physiologists have to tell us clinicians, and I'm sure Jeff is going to give us a very good answer to that. I know, I've seen some of his slides, so we look forward to that. Thank you.